This is a brief presentation trying to convince you that surgical anatomy is of interest to implant dentists, and we're going to overview our participation cadaver course. But before I start, I want to tell you about the clinical problems that we have. And in the most recent USA Health Survey, which was done in 2012, have shown that over 40 million people are edentulous. Many of these patients with or without dentures have lost significant amount of alveolar bone and are labeled dental cripples. In order to restore the atrophied jawbone to normal structure and function, which we also call bioengineering of alveolar bone, several surgical approaches for harvesting bone and transplanting it at deficient recipient sites has been developed based on extensive translational dental research. And results of this research will be part of this course. Now, in the top picture, you can see typical patients that have lost their alveolar bone, and the ridge is covered by the raised floor of the mouth, which is raised by the hyperactive mylohyoid muscle in these cases. And you can see his sublingual salivary glands sitting on the top of your ridge. And you can see the floor of the mouth and the sublingual caruncles for the salivary gland secretion. And this would be the area of the genial tubercles. And when we surgerize or expose that bone, you can see that we only have the basal bone left, and the alveolar bone of the mandible is gone as a result of loss of teeth, of the biomechanics loss on that functional bone. And you can see the mental nerve and vessels on the top of the ridge. You can see the internal oblique ridge with loss of the mylohyoid muscle, and you can see also in this area the buccinator muscle is lost. So the anatomy of that edentulous mandible is quite different. And you can see here the maxilla is more complicated because in the maxilla, the maxillary sinus, which I have the arrow on here, and this is the nasal cavity with the inferior nasal concha. That's the medial wall of the sinus. And you can see that the sinus have pneumatized or extended into the alveolar, or the remnant of the alveolar process. And you can see that the alveolar process lost its internal architecture. We call that osteopenia. And you're left with almost no ridge. And then the ridge that we see clinically is that thickened gingivofibrous tissue on the top. And this is the palatal side. This is the buccal side. And so the maxilla is more complicated, and we're going to present for you the maxilla little later. Now you can see the patient, of course we all accustomed to this, where he became pre-normal occlusion because mandible atrophies facially, where the maxilla atrophies posteriorly. As an end result, most of our patients have lost their premaxilla and their mandible is protruding, and you have the lower 1/3 is totally altered. So this is a clinical problem. So the advances of knowledge of bone biology, physiology, and biochemistry in the past 2 decades has led to the development of clinical procedures aimed at successful reconstruction or bioengineering of those atrophied jaw bone, either total edentulous or partially edentulous, using variety of bone grafts, local growth factors, dental implants. Results of the experimental studies in our laboratory and clinical trials also have shown the efficacy of using allogenic, which means bone bank material, and autogenic means from the patient blocks, and we fix it to the atrophied recipient sites, and we've shown through a lot of work and a lot of laboratory work that this works. Now, this procedure, the surgical procedure, require knowledge of clinical anatomy in order to assure the safe access to the jawbone without harming muscles, vessels, and nerves, and also to enable the operator, in this case would be a general dentist, to deal with unexpected complications such as hemorrhage, airway obstruction, and nerve injury. Many general dentists are interested in learning these procedures, as we know. These are reconstructive surgical procedures, and it's really should be labeled as medical procedures, because dental procedure usually is restricted to teeth and the alveolar process. Now, those patients don't have an alveolar process, so most of your surgery will be, even though it starts intraorally, it will end subcutaneously, as you will see in my brief presentation later. Now, this reconstructive procedure, surgical procedure, will be done, of course, on the maxilla and the mandible, or in other words, you become the physician of that lower 1/3 of the face. Now, unfortunately, most of the undergraduate dental education, and I have been in dental education for over 45 years, is so deficient that it does not provide even to the undergraduate level or even to the specialist, like oral maxillofacial surgeons, endodontists, periodontists. They do not provide them with adequate in-depth training in surgical anatomy. Now, the course objectives, which we have we have courses for 3 days, we have courses for 4 days, and I'm going to list for you some of these objectives that we have for our course. Our course has been 35 years old, so we have done it 6-7 times per year for 35 years. And of course, we update it as our knowledge is updated through research. So the first objective is to present our knowledge, current knowledge about bone as a tissue rather than bone as an organ. So to present the most up-to-date knowledge of the anatomy, physiology, and biochemistry of bone of interest to implant dentists. And this will be at the cellular, subcellular, molecular level of understanding. Number 2 is to discuss the local growth factors, and we will emphasize those that we have now and are available commercially for therapeutic use. And the example will be BMP2, and BMP stands for bone morphogenetic protein, and PDGF is platelet-derived growth factor. And many dentists use, of course, the plasma-rich platelets, the PRP, and that will include in the blood platelets PDGF, IGF. Many of those factors are mitogenic factors, so we'll discuss that too. Number 3, to present the experimental evidence that support the use of bone blocks, particularly bone, and stem cells and implants in the bioengineering of new functional alveolar bone, because we cannot do this complicated procedure without evidence. So you're always asked, what evidence do you have that this procedure that you're going to describe in this course is going to be supported by experimental evidence as well as results of clinical trials. Number 4, I always emphasize that the fact that if you become the physician of the lower 1/3 of the face, you have to do good physical exam of the head and neck, and a thorough physical examination of the head and neck, and the data has to be recorded before you do any surgery, because this is going to be the baseline for data that you would require to have in your record, because any post-operative complications or even just enlargement of lymph node, inflammation of lymph node, you need to know, is it caused by your surgery or is it something that the patient had before? And therefore, I prepared for you podcasts that would go over this step-by-step physical examination of the head and neck. Number 5, we will discuss the surgical anatomy of the maxilla and the mandible. These are the 2 organs that the dentist will be dealing with, very similar to ophthalmologists dealing with the eye, or ear, nose, and throat dealing with the ear, nose, and the throat of the patient. We deal with the maxilla and the mandible, and we will emphasize anatomical landmarks of surgical importance, physical examinations of that bone, and the study of the radiological images. We need to deal with the arterial blood supply, so you will know which arteries you're going to be interfering with or avoid to expose it. And we will emphasize the vessels that need to be protected during surgery. And we will deal also with venous and lymphatic drainage, very important, muscles attached to the jaws and their innervations, sensory nerves, particularly the ones that are most liable to injury during access to sinuses or alveolar ridges, such as mental nerve, long buccal nerve, lingual nerve, and those are the inferior alveolar nerve, of course, and those are the most commonly interfered with or injured nerves. Then we'll deal with the paranasal sinuses, anatomy, physiology of those, and radiological pathology. Number 6 is to discuss the complication that may occur during or after surgery, such as arterial hemorrhage, airway obstruction, and how to manage and deal with infection and with other complications. Number 7 is to discuss the anesthetic nerve block techniques, because I emphasize the fact that block anesthesia is very good. We can learn how to do V2 block anesthesia, bilateral, and that would be like general anesthesia, because you can work on the nose, on the sinus, and the maxilla with just 2 injections. That's an example. So then 8, will apply the knowledge learned in the lecture room in a laboratory setting, and that's unique about this course because we're going to use cadaveric heads for 2 days, and we will be dissecting the pertinent region of the head. We're going to expose subcutaneously the arteries, the nerves, and the muscles of the jaws, and then perform the surgical procedures that we're going to learn, like the sinus lift procedure, how to harvest bone blocks from mandibular symphysis and ramus, how to use bone bank blocks, and how to put implants, insert implants in the edentulous ridges. In other words, on the cadaver, we're going to reconstruct or bioengineer the alveolar bone, either ridge augmentation or floor sinus augmentation, how to protect the arteries, how to protect the nerves that we expose under the skin while we're doing it intraoral surgery. Then, our surgical anatomy continuing education course will provide didactic and laboratory participation of over 48 hours, and it will provide you an adequate background and confidence in conducting soft tissue, bone, and sinus surgery without harming your patients. Now, the surgical anatomy of the maxilla and the mandible in our course is going to take about 4 hours, but the following dental XP presentation of around 40 minutes or so will give you only a brief consideration of the surgical anatomy of the maxilla, and hopefully it will whet your appetite to join us in the next full course. So let's start with the maxilla. What I'm showing you here, on the left side we have half a maxilla, but we're looking at the anterior view, and the second figure we're looking at the lateral view. And so let's start with the anterior view and see what we're seeing here. We're seeing the anterior nasal spine, which is a projected bone. That projected bone from the maxilla carry the the nasal septum. So the septum of the nose, the cartilage, sit on that anterior nasal spine. So if you're doing an orofacial or mucoperiosteal flap and you're reaching and seeing that anterior nasal spine, don't trim that, because if you trim that bone or you take it for a graft like some people advocated, you will end with drooping septum of the nose, which looks disfigure the patients. Then you can palpate on your patient the anterior nasal aperture. You see that I'm outlining here. And then you are looking at the alveolar process. And in the alveolar process, below the vestibule or the mucobuccal fold, as we all know as dentists, so if you reflect the cheek and the lip, and you'll see that mucosa reflection on the inner side of your lip, Below that, you have the alveolar process, and you can palpate the alveolar bulging of on the root of the central incisor, lateral incisor. Immediately as you get to the canine, we all know that we have the canine eminence, and the canine eminence is characterized by the fact that it goes beyond that vestibule and reach subcutaneous. That's why any leakage from the apex of the canine ends in a subcutaneous, not submucosal, and it can spread, as you will see, to the lower eyelid and the upper eyelid because of that anatomical relationship. Now, distal to the canine eminence, we have a depression. That depression is the famous canine fossa, and the canine fossa, you can see that inferiorly it can reach the alveolar process and it's intraoral, and superiorly it can go superiorly all the way to the infraorbital margin. That's the infraorbital margin. And while you're taking a periosteal elevator and reflecting the periosteum on the canine fossa, you can reach the infraorbital nerve and vessels going through that infraorbital foramen. So that's something that we will talk about and we have to avoid during our surgery. So why is it important that we have that canine fossa? The canine fossa is the site where we enter the anterior wall of the sinus. So when we do sinus lift procedure, we're doing our surgery and exposing the membrane by removing the bone in the canine fossa. Notice that distal to the canine fossa, we have the root of the zygoma. That is something that you can palpate, and you should palpate in every patient because it's a very important landmark. That's where the zygoma join the maxilla. And so between the root of the zygoma and the canine eminence is a canine fossa. And we will talk more about some of the important muscle attachment and nerve supply in this area, because this is the area that you're going to do surgery above the line of the vestibule. Now, if we take the root of the zygoma here as a landmark, you'll find that anterior to it, we have the anterolateral wall of the maxilla that I described some of the features that are important surgically. Now, distal to the root of the zygoma, we have the posterolateral surface. And the posterolateral surface, if we draw the line again, which you will see it in the next figures, if we draw the line, below it is the alveolar process, and you can see that it ends with the maxillary tuberosity. And if you exceed that vestibular line, you can go onto that surface. That surface is really the anterior wall of the so-called infratemporal fossa. And if you extend your periosteal elevator, you can dig up all the way into that wall. That wall is the anterior wall, as I said, of the infratemporal fossa. And as I was saying, that the line of the vestibule, superior to it, you have the posterolateral surface of the maxillary sinus. And if you continue on that posterolateral surface, you will go through the infraorbital fissure and you reach the orbit. So that's a dangerous zone, Also, in the posterolateral surface of the maxilla, the arrow points to those canals or channels. Those canals are the sites, as you will see, where the posterior superior alveolar artery and posterior superior alveolar nerve were coming in. So if you are looking at the alveolar process, if you go beyond, you make a vestibular incision, you go beyond that incision, you are in the infratemporal fossa, and we have to avoid injuring the artery, which is a serious hemorrhage. It can lead to a serious hemorrhage, posterior superior alveolar artery. And if you cut the posterior superior alveolar nerve, you are going to create, because it does have mucosal branch to your cheek and the vestibule, you will have anesthesia of the area. And then you'll have also anesthesia to the gingiva opposite to the third, second, first molars if you cut the posterior superior alveolar nerve. Now, hemorrhage, while you're doing a sinus lift from the posterior superior alveolar artery, we'll see is quite dangerous because you have to pack the sinus. And we'll talk about that later on. Now, I told you that the maxilla is pyramidal in shape. The root of the zygoma is the apex of that, of that pyramid. One surface is the anterolateral surface. The other surface is the posterolateral surface. And the third surface is the orbital surface. So you can see that the orbital surface, which is the floor of your orbit, is the roof of the maxillary sinus. The posterolateral surface is the posterolateral surface of the maxillary sinus. The anterolateral surface, the canine fossa, just to the canine only, is that anterior surface of the maxillary sinus, you see. And then beyond the canine eminence, and the canine eminence itself, and anterior to that till the anterior nasal spine, is the alveolar process, you see. Next slide, I marked the vestibule. So that's the line that's marking the vestibule. Inferior to that, you have the alveolar process. Superior to that, we have the anterior wall of the infratemporal fossa, and the arrow point to the infraorbital fissure, like I told you. So many times we'll be doing surgery on the sinus and will affect the orbit. And so we have to be very careful, because the maxillary artery enter this and you create a huge hemorrhage if you're not careful with periosteal elevation all the way up here to create a window posteriorly, you see. And so this is summarize what I just told you. Now, what's under the mucosa buccally, opposite to the first, second, third molar, is a buccinator muscle. So we have a buccinator muscle barrier that prevents sometimes when you have an infection or exudates at the area of the third, second, first molar, they escape and they create a vestibular abscess. But if they go beyond that apex, beyond the vestibule, and they go above the buccinator, then you have a serious infection in the pterygomandibular space and also in the infratemporal fossa here. Now anteriorly is different, because between, if I go back to this and I put the line here, we don't have a muscle barrier between the, or opposite to the center incisor, lateral and canine, and the first premolars. We have no muscle barrier, so escape of fluid or infection beyond that line will go on the face, and it will cause swelling of the lower eyelid and the upper eyelid. So sometimes you will be doing surgery anteriorly related to the premolars, canine, lateral incisor, and center incisor, and you will be sort of like surprised to see that the whole face is swollen, including the lower eyelid and the upper eyelid. The explanation is the fact that we don't have a barrier, muscle barrier. So let's go to now the CT scan. This is a reconstructed image of a spiral CT, which is a very high contrast. As you can see the skull of the patient here. And I drew the line of the vestibule. Below that line, your intraoral or submucosal. Above that line, your subcutaneous. And when we look at the anterolateral wall, like I showed you, you can see the infraorbital foramen. Now, the infraorbital foramen is sandwiched by two muscles. One muscle that takes origin above the foramen, and one muscle that takes origin below the foramen. The one that takes the origin above the foramen, we call it the levator labii superioris. It runs from that bone down to the upper lip. The one below the foramen is called the levator anguli oris, or the dentists like to call it the caninus muscle. So if you are doing a mucoperiosteal flap or doing a vestibular incision and you go beyond that vestibule and you're digging into the canine fossa, you can detach the caninus muscle and you can injure the infraorbital nerve and vessels, which can lead to a facial hemorrhage that cause hematomas on the face and disfigurement, and later on you will get either neuritis, inflammation of the infraorbital nerve, and the patient will experience pain related to the side of the nose, the upper lip. He can have serious, or if you detach it completely, you'll get anesthesia of that middle part of the face. So we have to be very careful, even though we're doing it intraorally. Now, this is a actual patient clinically, and by reflecting the lips and cheeks, I want you to pay attention to the fornix or the mucobuccal fold area. Because as I said, below that you're intraoral, you're doing dental-alveolar surgery. Above that, which you have to be above that if you're doing sinus lift procedures, or if you're dealing with an atrophied jaw without the alveolar bone, very little incision and you'll be subcutaneous. Then in the maxilla, you have to avoid detaching the levator anguli oris or injuring the infraorbital nerves and vessels. Buccally, we know that we have a barrier here, the buccinator muscle. So if you go below that, above that barrier, below that barrier, you will have the alveolar process. Above that barrier, again, you are subcutaneous. And in this area, you are dealing with the anterior wall of the infratemporal fossa deep in the head, and you can reach the orbit by, if you're overzealous, reflecting the periosteum in these areas. Now, the medial wall of the maxilla is really the lateral wall of the nose. And you can see, I summarized this here, but I'll describe it. You can see, describe it on this slide. You can see the opening of the maxillary sinus. And the maxillary sinus opening is very close to the floor of the orbit rather than to the floor of the nose. So it's higher up. And the reason it's higher up, it opens into the middle meatus of the nose in an area called the hiatus semilunaris, and you'll see a picture of that in a minute. And the reason it's higher up is because the sinus is lined by pseudostratified ciliated epithelium, and the cilia beats toward the ostium. So that's why if the cilia was beating down the ostium, then the ostium will be down here, you see. So it's beating all the way up, cleaning the sinus, which is supposed to be sterile, and it's opening now. You notice that this opening is quite big, but in actuality, we can see this in the next, and then I'll come back. You can see here the sinus opening, and the sinus opening is really a canal. Sometimes we call it opening, but that's a mistake. It's supposed to be a canal. You can see an opening toward the sinus cavity, an opening toward the middle meatus of the nose. And so it's a canal lined by pseudostratified ciliated epithelium. So when you have inflammation of the sinus and it gets swollen, you obliterate that canal, and the air within the sinus will be absorbed, and then you get more hyperemia and transudate. So you get fluid build up, and when the fluid build up, it will go by gravity to the floor of the sinus here. And this opening is in the middle meatus of the nose. This is the middle concha, and this is the inferior concha. So the fossa, the middle nasal fossa, is between the two, and that's where the canal is open. So we have to have a patent canal in order to have a healthy sinus. Once we have obliteration of the canal, then we have a problem with the sinus. Notice that that canal is quite close, or quite narrow, and so that opening is obliterated by another piece of bone called the uncinate process of the ethmoid bone. And when somebody is exploring your sinus with fiber optic like ENT people, they fracture the uncinate process, and that leads to dilation of the sinus opening. Now I want you to also see that the maxilla send a process called the palatine process, and it makes the anterior 2/3 of the hard palate. So what makes the posterior 1/3 of the hard palate is the palatine bone. And the palatine bone has a horizontal plate, and then it has a vertical plate. And the vertical plate juxtaposes and articulates with the maxilla posteriorly into your nasal cavity, because this is the lateral wall of your nasal cavity. And the vertical plate make the medial wall of the pterygopalatine fossa, which is right behind your maxilla. And it has an opening here called the sphenopalatine foramen. The sphenopalatine foramen is a window from the pterygopalatine process that you can access through something called the pterygomaxillary fissure. And so if you're injecting local anesthesia, sometimes it drops and the patient will have nasal dripping of the anesthesia because of that foramen that you see here, the sphenopalatine foramen. You see, so that's the sphenopalatine foramen that you can access from the periphery or peripherally, as if you're injecting a V2 block anesthesia. So this is the palate. So you can see here the anterior 2/3 of the palate is the palatine process of the maxilla. And you can see the incisive foramen where the incisive nerve comes through. And then the posterior 1/3 is the palatine process of the palatine bone, a different bone. And this is the greater palatine foramen, and this is the lesser palatine foramina. And this is called the pyramidal process of the palatine bone, which you will articulate with the sphenoid bone. These are the pterygoid plates of the sphenoid. And therefore, I'm showing you this because intraorally you can palpate the maxillary tuberosity, and behind it there is a notch called the hamular notch. The hamular notch, the roof of the hamular notch, is that pyramidal process of the palatine bone, and behind it is the pterygoid plates of bone. This is the medial pterygoid plates which end with the pterygoid hamulars that you can feel with the tip of your tongue projecting down. So if somebody tell you where the maxilla now articulates, it doesn't articulate directly with the sphenoid bone. It articulates with the palatine bone and then the sphenoid. So you have the sphenoid bone, palatine bone, and then the maxillary tuberosity. Now, we talked about the sinus lining, and you can see the alveolar recess and the lining membrane. Now, the alveolar recess is what we really augment. So when we're doing a sinus lift procedure and bone grafting, we are talking about alveolar recess bone grafting, you see. And I described for you here the coronal cut through the head showing the maxillary sinus with its opening in the middle meatus of the nose. The medial wall of the sinus is the lateral wall of the nose. The floor of the sinus extends into the alveolar process. We call that the alveolar recess from the first premolar to the third molar. Note the close relationship of the sinus to the ethmoid air cells. So sometimes you'll be doing surgery on the maxillary sinus and the patient come up with ethmoiditis and they have pain on the side of the nose extending to the superior orbital margin. That's because of the relationship. So when we're doing even sinus lift of the alveolar process, you might get an sinusitis inflammation, traumatic sinusitis, that can extend into the ethmoid air cells. The roof of the sinus is also, as you can see here, is the floor of the orbit. So one has to make sure that any orbital or eye complications can come secondary to sinus surgery because of the close relationship. Now, when we fracture the floor of the orbit, sometimes with a facial fracture, sometimes the eye will drop into the sinus. We call that enophthalmia, or dropping of the eye into the sinus, and we can correct that surgically. Now, this is the same picture that I showed you before, and the line show the fornix, and the yellow area is the sinus opening. So that's where we open, we make an oval window created in the bone that will expose the lining membrane. If the origin of the caninus muscle, which originate below the infraorbital foramen, is violated, then you can injure the infraorbital neurovascular bundle, and that's what we need to avoid. And that's what you will do on the cadaveric surgery. So you will see exactly where the infraorbital nerve and vessels, and we can do a simulation, either doing correctly, avoiding that, or doing incorrectly and hurting the infraorbital nerves. So reaching above the fornix line, distal to the root of the zygoma, you may injure the posterior superior alveolar nerve and artery, like I told you, which comes through the posterior wall of the sinus. Now, I'm showing you this because the connection of the maxilla, like you are the doctor that dealing with the maxilla, but you have to remember that the maxilla articulates with quite a bit of adjacent bones. Like this, in this case, you can see the zygoma, And you can see the frontal process of the maxilla articulating with the nasal bone and with the frontal bone. And you will see in the next picture that we also articulate with the palatine bone, we articulate with the ethmoid bone, and it articulates with the sphenoid bone. So if you're doing surgery on the maxilla, sometimes you get the patient come back with non-specific pain that you wonder why he's complaining about pain related to the zygoma, pain related to the orbit or the frontal bone or the nasal bone, because the maxilla is covered by periosteum, and when you irritating the periosteum, you might get a periosteal inflammation. That periosteum does not end at the maxilla, but it also runs on the adjacent bone. So remember that, because that non-specific pain post-operatively is very hard to diagnose unless you know that concept. So that's what you need to explain to your patient. Now, we did the hemimaxillectomy here to show you those bone articulating with the maxilla. So in red, you can see the palatine bone, and this is called the pyramidal process. These are the two pterygoid plates of the sphenoid, and that's, as you all know, lateral surface give origin to the lateral pterygoid muscle, and the medial surface give origin to the medial pterygoid muscle. So those are very close, and sometimes you will see the medial pterygoid muscle, which has also a tuberal head. It takes origin from that maxillary tuberosity. So when you're doing surgery and mucoperiosteal flap reflection, posteriorly you might see that muscle. Now, let me show you the muscle attached to of not all of them, but the muscles that we are interested in. You can see this is the orbicularis oculi muscle, the sphincter, and many of us have this muscle overlap the levator labii superioris. So the levator labii superioris, which elevate the upper lip. So when you ask the patient to show his teeth, these dilator muscles are the one responsible for elevating the lip, along with many other muscles that we will mention during the course. But you can see we cut the muscle here. You can see the infraorbital foramen and the vessels and nerves. And below it is the levator anguli, or the caninus muscle. So again, the arrow is pointing to the neurovascular bundle that you have to be very careful with. The other muscle here is the orbicularis oris muscle. The orbicularis oris muscle does not constitute a barrier because most of it is attached to or is within the soft tissue of the lip, and therefore you can get a scab of exudates or pus without any barrier preventing it from reaching below the lower eyelid or the upper eyelid or the swelling on the facial aspect of the face. So edema, blood or edema from canine to canine region, and commonly lead to facial swelling, and that may spread to the upper and lower eyelid. You can see here, again, the levator labii superioris, the levator anguli oris, you see, and then the orbicularis oris muscle without attachment. It has a very minor attachment to the bone. And then I want to show you the buccinator, and the buccinator take origin from the base of the alveolar process of the maxilla and the alveolar process, base of the alveolar process of the mandible. We call that the external-oblique ridge, and it inserts. Upper fiber go to the upper lip, lower fiber go to the lower lip, and the middle fiber will crisscross. Posteriorly, where it disappears here, the buccinator is going to go medial, and it will cross the retromolar triangle to join the superior constrictor muscle through the pterygomandibular raphe. And this is an area that you're going to be dissecting. If you go above that buccinator, as I said, you will be injuring the posterior superior alveolar artery and nerve, which we shouldn't. Now, when we're dealing with a patient that lost his alveolar process, which are your patient in this case, you will see that the muscles that we mentioned, because of the resorption of that alveolar bone, are just at the top of the ridge. So for example, if you make an incision in that patient, you're immediately going to be subcutaneous because the bone have resorbed, and in this case, that patient, that person have lost the bone attachment, and so the buccinator is totally in the cheek, and therefore any retromolar pad, ridge incision, you will be subcutaneous. The same would be in the maxilla. So you have to be very careful because the anatomy is altered in your patients. So you have to know your anatomy real well. Now, how about the innervation of the maxilla and the nasal cavity? We know that we are dealing with the maxillary division of the trigeminal nerve. We call that V2, Roman numeral V, and then number 2, because that's the second division. Now, let us go over the course of the maxillary division of the trigeminal first. Then I'll tell you the most important branches that you need to know about. The V2 exits through a foramen called the foramen rotundum, and that's a foramen in the middle cranial fossa. And the foramen rotundum will take the nerve into a fossa behind the maxilla called the pterygopalatine fossa. Sometimes we call it spheno, from the sphenoid, palatine because the medial wall is palatine bone. Sphenopalatine fossa or pterygopalatine fossa is the same. Then it will exit through the infraorbital, through the pterygomaxillary fissure, and it has a little portion in the infratemporal fossa. So I call the first part pterygopalatine portion of the maxillary division. Then the small part in the infratemporal fossa, we call it infraorbital portion of the maxillary division. Then it enters the orbit via the infraorbital fissure, as you can see here, and it runs on the floor of your orbit, run into the canal, and then open on the face, like we talked about, as the infraorbital foramen, and then it will terminate as a nasal branch to the side of the nose, labial branch to the lip, skin, mucosa, and the gingival portion, and then it will also have a palpebral branch to the inferior eyelid. You see? So that we call that the course of the maxillary nerve. Usually when we give a V2 block anesthesia, we reach the nerve in the pterygopalatine fossa. So we approach it from the posterolateral surface of the maxilla, reach the pterygomaxillary fissure and inject, then you get block of that maxillary division. Notice, let's talk about the branches. Now in the pterygopalatine fossa, we have a branch called the descending palatine nerve that reaches the palate and supply the mucosa of your palate and the palatal gingiva opposite to the molars, premolars, but the anterior teeth get their branches via something called the incisive nerve. So that's the descending palatine nerve. The infraorbital portion gives us the posterior superior alveolar nerve. That's the only branch that will go to both bone and teeth, and the teeth will be the third, second, first molar and the alveolar bone. But then it also gives a mucosal branch. That mucosal branch supply the buccal gingiva opposite to the third, second, and first molar, but it gives also a branch to the cheek. So when you injure or cut that nerve, you get anesthesia opposite to the molars and also to the mucosa lining the cheek. Now the other branches come from the infraorbital nerve called the middle and anterior superior alveolar nerve. The anterior and middle superior alveolar nerve make a dental plexus in the alveolar bone, and then it gives the dental branches to the first lateral canine, premolars, that's the anterior superior alveolar, and the middle superior alveolar give a branch to the mesiobuccal root, you see, of that molar tooth. Now what happens when we extract the teeth, that these branches will degenerate, particularly the dental branches, but some of them sometimes remain into the bone. So sometimes you would be inserting an implant and the patient will complain about pain related to his first molar. He will think that the pain is coming from the first molar because that implant put pressure or compress the remaining nerve within the bone. The same thing happened with the inferior alveolar nerve in the mandible, you see. So those are the branches of V2, and you can see here that the lining of, below the lining of the sinus, we have several nerves that belong to the posterior superior alveolar, middle and anterior superior alveolar nerves that we can block through injecting through the infraorbital foramen canal. So we can block the infraorbital nerve, anterior and middle superior alveolar nerve via infraorbital nerve block anesthesia. And remember that when you're doing surgery on the sinus, patients will complain about pain related to the alveolar coverage of the teeth that doesn't exist there. So, and sometimes they will develop infraorbital nerve neuritis also. So that's why we're learning about this, you see. Now, how about the arterial supply to the maxilla? The maxilla is endowed by the many arteries, arterial supply. And so the main artery is the maxillary artery, which also give us, very similar to the nerve, descending palatine artery to the palate, posterior superior alveolar artery, middle superior alveolar artery, anterior superior alveolar artery, and also the sphenopalatine artery in the pterygopalatine fossa, which give us the septal artery that become the incisive artery that communicate with the palatine artery. So you can see that it's very, very good blood supply. In addition to this, and that might surprise you, we have 5 other arteries that erupt in the neck, go on the lateral wall of the pharynx, penetrate the superior constrictor muscle of the pharynx, and reach the soft palate, and then resupply the hard bone of the maxilla. So let me name those arteries. We have from the facial artery, which arises from the external carotid artery, and from its cervical portion, it provides 2 arteries. One is called the ascending palatine. The second one is called the tonsillar. And both of these arteries run on the lateral wall of the pharynx and reach the tonsillar area, soft palate area, and the maxilla. Then the lingual artery, and the lingual artery will supply 2 arteries called the dorsal lingual arteries. Then the 5th artery comes from the external carotid itself, called the ascending pharyngeal artery. So what happens? All of these will approach from the palatal side, the bone of the maxilla. That's why in orthognathic surgery, when we cut the anterior, middle, and posterior superior alveolar artery and the descending palatine artery, and nothing happened to the maxilla because it's supplied by these collateral branches. But if I go and do a palatal flap reflection along with orthognathic surgery, then the maxilla will slough away. It will necrose. So remember that you have those collateral circulation through the palatal mucosa. So you cannot do facial mucoperiosteal flap and palatal mucoperiosteal flap because that's too dangerous. Now, how about the venous and lymphatic drainage? From the maxilla and maxillary sinus, the lymph from the maxilla goes to primary lymph nodes. Those primary lymph nodes is called the submandibular lymph nodes. And so these are the submandibular lymph nodes that we see here. So when you're doing surgery on the maxilla, you might expect to get lymphadenitis related to those submandibular lymph nodes that you need to palpate before the surgery, because after the surgery they might be painful, tender, soft, but it's still mobile. You see, if you do the anywhere in the maxilla, you get the submandibular lymph nodes. That this will connect with the superficial cervical and the deep cervical nodes also. How about venous drainage? Most of the maxilla drain into the maxillary vein, and the maxillary vein is deep in the head, in the infratemporal fossa area, and it overlies the lateral pterygoid muscle. That maxillary vein communicate with a plexus called the pterygoid plexus of veins, and the pterygoid plexus of veins communicate via emissary veins to the cavernous sinus. So anywhere in the maxilla, the infection can spread through the maxillary vein to the pterygoid plexus of veins and can cause cavernous sinus infection and thrombosis. Also, from the upper lip, you can drain into the facial vein, and then the deep facial vein communicate with the pterygoid plexus of veins, and the same thing can happen. So any infection of the upper lip or the buccal gingiva can drain into the facial vein, deep facial vein, pterygoid plexus of vein, emissary veins to the cavernous sinus. So we have to be aware of this as a possible complications from surgery on that maxilla as our organ that we're dealing with. So in closing, I want you to remember the following. Root of the zygoma is palpable intraoral bony landmark of surgical importance. It represents the location of the apex of the maxillary sinus. Anterior to it is the anterolateral wall of the maxilla. Between the root of the zygoma and the canine eminence is the canine fossa, or the site of lateral window access to the maxillary sinus. Accessing the sinus through mucopreacial flap may detach the caninus muscle and can cause injury to the infraorbital nerve or the neurovascular bundle. Therefore, clinical location, you have to localize clinically the infraorbital foramen and mark it on the scan prior to accessing the canine fossa. This is very important safeguard against injury to the infraorbital nerve and vessels. The vestibular fornix or the mucobuccal fold locate a plane that divide the maxilla into intraoral portion and a subcutaneous portion. So therefore the fornix between the right and left first premolars has no muscle barrier, like I said before, while the posterior fornix at the molars has a buccinator as a barrier. Surgery at the premaxilla may cause facial swelling that may spread to the upper and lower eyelids. Violation of the buccinator opposite the posterior molars may injure the posterior superior alveolar artery and in the infraorbital fossa and posterior wall of the maxillary sinus, and may sever the posterior alveolar nerve, which we need to avoid, obviously. Now, I need to remind you that this course is not only a didactic course, it's a participation course that has an addition, in addition of 2 days of didactic lectures, 24 hours of laboratory using human heads and cone beam imaging. The participant will expose vital structures via dissection, then perform surgical procedures while visualizing those subcutaneous sensory and motor nerves and arteries that need protection. If you need, of course, details about this course, or if you want to join us, please write to Dr. Sharawi at anatomyacademy@gmail.com. Thank you very much.